and colleagues. I am truly delighted to welcome each one of you to Allied Health Research Symposium organized by IHAS, the Amity Institute of Health and Allied Sciences. Today's event is a research, clinical wisdom, and relentless pursuit of evidence based practice in allied healthcare. Our theme today, Bridging the Gap for Clinical Expertise to Evidence Based Practice, is a call to action. A reminder that the best clinical care is built on a foundation of research, innovation, knowledge sharing. And that is exactly what today is all about. We are privileged to have with us today some of the most distinguished academicians, researchers, and clinicians across the India and indeed joining us virtually from across the globe. Let us begin by acknowledging the eminent dignitaries gracing this occasion. To invoke wisdom and positivity, we now proceed with the auspicious lamp lighting ceremony. May I request our esteemed dignitaries to kindly come forward for the lamp lighting ceremony, making the beginning of today's presentation. I invite forward Professor Dr. Jaswanta Sethi, sir. Yeah. या ब्रह्माच्युतशङ्कर प्रभृतिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाडामहा शुक्लां ब्रह्मविचारसारपरमम् आद्यां जगद्व्यापिनीं वीणां पुस्तकधारिणीमभयदाम् जाडान्धकारामहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्. Thank you so much, everyone. I request our esteemed dignitaries, Dr. Jasubanta Sethi, sir, Director IHAS, Dr. Tanveer Nawe, Deputy Dean, Health and Allied Sciences, to please come on the dais. Dr. S.K. Srivastav, sir, Mentor IHAS, Dr. Professor B.C. Das, sir, Dean, Health and Allied Sciences, and Professor Dr. Charandeep Tandon, sir, Additional Pro Vice Chancellor, to come forward on the dais. We welcome you all to this auspicious symposium. To formally inaugurate today's symposium, it is a movement of immense pride and honor to invite the Director of IHAS, Professor Dr. Jasubanta Sethi, sir, to deliver the inaugural address. Sir's visionary leadership and dedication to academics and research excellence have been the guiding light for all of us at IHAS. Sir, we most respectfully invite you to kindly come forward and inaugurate this symposium.
Thank A very good morning. With blessing of the Almighty, Founder President Dr. Ashok K. Chauhan, Chancellor Dr. Atul Chauhan, Vice Chancellor Dr. Balbindra Shukla, I just take this opportunity to go ahead for this today's program to welcome this three dignitaries on the dais on this auspicious day of IR Symposium. We are so honored to have Professor Dr. Chandradev Tandonji, Additional Vice Chancellor and Dean Bioscience and Biotechnology, who has kindly consented to honor this occasion, along with my budding physios, occupational therapists, and physiologists here. So thank you, sir, accepting our invitation coming over. Professor Dr. B.C. Das ji, the leading father figure in IAS. So with all his advice, we always take in clinical and non-clinical areas of my three departments. So thank you, sir, accepting our invitation coming over here to bless this occasion. Dr. S.K. Srivastava ji, the mentor I has, who has guided many instances in my three departments to all my faculty and students for many needs. So thank you very much, sir, for accepting our invitation to coming over here to bless this occasion. Dr. Tanvir Nave ji is a very pleasant and always smiling personality. So he never says no in any occasions. He says to go ahead. His utmost help will be in 12 o'clock night. So thank you, sir. Thank you very much for accepting invitation and coming over. We have Professor Dr. A.G.K. Sinha ji from Punjab University, Patiala, online. So today he is going to give his visionary and informatives on Allied Health Research Symposium and the theme of bridging the gap from clinical expertise to evidence-based practice. So thank you, Dr. Sinha, coming over or coming online and sharing this auspicious dice and giving the information to my all IAS, the faculty and students. Madhusudan Palji, the scientist F from Defense Institute of Physiology and Allied Sciences, who has sent the message that he couldn't join, and we hope that he will join in near future in our next organized program. Then over here we have Dr. Neeraj Kumar Mishra ji, this from the Department of Occupational Therapy, GB Pant Hospital. It's a very renowned hospital where our many students are posted. And thank you, Dr. Neeraj ji, accepting our invitation coming over here. Dr. Olga Budasova, yesterday she has given a very good CME and the technical session. So, Dr. Olga, yes, I can see you. So, thank you, Dr. Olga. You are always here with us in IAS and IMIT University. And once, yesterday, I think Dr. Srivastava said that once you are IMITian, always you are IMITian. So, you came today also on this online to give your valuable talk. Thank you, Dr. Olga. Professor Dr. Prasun Priya Naik from AIMS Jodhpur, who is the president in Physiological Society of India, has kindly accepted and consented to be online to give his valuable information on today's theme on this Allied Health Research Symposium. So thank you, Professor Naik, Dr. Madhuchanda Mohanty, HOD Occupational Therapy in IPH Delhi under Government of India, has consented to give to come over here, but she messaged us that she will reach by afternoon in her time of giving this valuable lecture. So thank you all. Thank you uh, all these things, and wherever we got the very valuable message and blessing from our honorable vice chancellor, who has given this information that to go ahead with our blessings for this today's function. Thank you all. Thank you very much for this. Thank you.
Thank you so much, sir. Your words set the perfect tone for today's program. We are deeply grateful. It is now our privilege to invite Professor Dr. Tanveer Naved, sir, Deputy Dean of Health and Allied Sciences, to deliver the welcome address. Sir's dedication to academic excellence and the growth of allied health sciences at Amity University has been truly remarkable. We welcome you, sir.
Very good morning to one and all. With the blessing of Honorable Founder President Sir, respected Chancellor Sir, respected Vice Chancellor Madam, and on my personal behalf, I extend a very warm welcome to this one-day symposium being organized by our AIHS Institute. I extend a very warm welcome firstly to our eminent speaker of the day, Dr. Neeraj Kumar Sir from GB Pant Hospital, and I extend a very warm welcome to all the experts who have joined online or maybe joining shortly this symposium. My sincere thanks and welcome to our respected Dean, Dr. B.C. Das Sir, respected Chandradeep Tandon Sir, the Additional Pro Vice Chancellor, our mentor, Dr. S.K. Srivastava Sir, and our dynamic HOI, Dr. Jasavanta Sethi Sir. Today I have gone through the program of the day and find that it's a very useful session being organized for our student. MIT being a research and driven university always give ample opportunities for our students to interact with various experts of the field, and today I think 7 to 8 expert is going to deliver the scientific deliberation, and I'm sure that it will be very beneficial to our students. I wish this symposium a grand success, and I once again welcome you all. Thank you.
Thank you so much, sir, for those warm and thoughtful words. We are grateful for your continued guidance and support. We now have the privilege of inviting a distinguished academic leader, Dr. S.K. Srivastava, Senior Director in the area of Health Sciences, mentor of IHAS and advisor at FPU.
Yes.
Sir's broad expertise and mentorship have shaped the landscape of health sciences and education at Amity. Sir, we respectfully invite you.
Thank you. Morning, everybody. Good morning. Esteemed guests on the dais and attendees of the dais, guests of the dais. It is this outcome of the blessings of Honorable Founder President, very dynamic Chancellor, and our beloved Vice Chancellor Madam, that we conduct such type of very valuable programs off and on very regularly with many of the departments. But today, what I found that this topic has been chosen so intelligently. It is a very practical thing. To my own perception on clinical research is as good as any one of you, any one of your perception. But when it is applied to the patient, then the experience counts. So, what is the experience? This topic tells you evidence based. Evidences are based on the patients. How many patients you daily examine, and how clinical findings are indicated. The number of patients you examine, their experience will be richer and richer. Because every result is not thumb rule for every patient. The result of the clinical researches are uniform. In any of the lab you'll go, you'll find the same result, same observation. But when implemented to the patient, it might differ from patient to patient, region to region, experience, the body, physiology of the human body, and the nature of the patient varies in terms of accepting the clinical outcomes and result. So this is very important to connect the clinical researches with evidence, means with the implementation of the clinical observations, clinical results on the patients. So better if you put down that similar kind of patient, similar problem, having similar problem is giving the same dose of medicine, same therapy, but results are different. If you note down why are the result, there is a difference in result, then you will find there is a huge change in the acceptance nature of the patient. And that is where the experience of the doctor or the physiotherapy is taken into account. So, for our new students, my humble submission and suggestion will be whenever you are examining any patient and giving prescribing any patient to any kind of treatment or the therapy, also take care of the attitude of the patient, nature of the patient, and the way the patient is accepting your prescription, and also at the monitoring stage, what were the lacking and slackness of the patient that he could not do, could not follow your prescription, and the result varies. For in the two to three patients, you'll find the result of the outcome varies. And when you observe, when you note it down, and becomes a good data, then you can very well analyze how evidence-based practice is important to implement the clinical observations, clinical outcomes. So I feel today you all will understand with the experts that what is the importance between clinical observations, clinical outcomes, and evidence-based practices. I feel the topic chosen by our HOD and other experts is very intelligently chosen, and you will not feel bored during the day because I have seen the variety of the topic is very interesting. Make it more interesting by interacting with the experts. You raise as many as queries as you can, then only it will be good for you and also interesting for the presenter. So all the best to all of you. I hope this one-day workshop will be very useful for the participants as well as our faculty who will understand the depth of the subject. Thank you all. All the best to all of you.
Class? Okay.
Thank you so much, sir, for your warm and thoughtful words of welcome. We are grateful for your continued guidance and support. I now take the privilege to invite to stage Professor Dr. B.C. Das Sir, Chairman and Chair Professor at AIMMSCR and Dean of Health and Allied Sciences, Amity University. Sir's scholarly contributions and research leadership make him the ideal voice to illuminate the theme of today's symposium. We warmly and respectfully welcome you, sir.
Thank you. Thank you. Good morning. Okay. So another yesterday we had the CME. Today is another symposium, and it's very important not only for clinicians but also for the students. Very important those who are going to practice second year, third year, fourth year. So, but it is important. Basic principles. So, what is this student symposia? Is the Allied Health Research Symposium. expertise to evidence-based practice. I think I will elaborate a little bit later on, but it is also, you can say, I would say rather, connecting the dots between the clinical practice and the evidence, the clinical expertise and the evidence-based practice. So, at the outset, I most respected Honorable Founder Presidents Dr. Ashok K. Chauhan, our dynamic Chancellor Dr. Atul Chauhan, and Honorable Vice Chancellor Madam Professor Dr. Balvinder Shukla, and also we have Vice Chancellor Professor Dr. Chandra. So he himself is a scientist, chemist and researcher scientist. So it is a good opportunity that we have a chancellor dealing with the research and others aspects that he is probably, he was sometime before he was our colleague, he is also the dean of the bioscience and biotechnology. So it's good that many of the things we feel very convenient that when you propose something, extra mile to go and convince and say things. So easily we will understand and support it. So that is one of the good things that is new development in the university. So, and all the experts, speakers, esteemed speakers, those who have agreed to come physically, Dr. Mayers Sharmaji, Mishraji from GV Hospital. You must have seen me because you must have come later, but then I'm regular visitors of GV Pant and Maulana Azad. We were there, I was there in ICMR 25 years in third floor of Maulana Azad Medical College. This is the Dean's Block, third floor. So there are several collaborators from, including Anil Agarwal, the previous director. So other people. So welcome to this symposium, and also those who are in online. There are few people in online and some people will be joining later. So, but all on the dais, Professor Srivastava, Professor Tanvir Nabad, my colleague and Deputy Dean, and of course the Director IHAS, Professor Sethi, and all the colleagues on the dais, and the health and allied sciences, the occupational therapy as well as physiology, medical physiology, and also other students, also a colleague from thinks he belongs to health and allied sciences, so he's good. So nice. We sometimes also need to, he is doing a lot of clinical trial and all, need to understand also clinical aspects that which clinicians, but as Professor Srivastava said, it's a great thing that the topic was selected. I would say it was not much discussed with me, but he came with this topic. So I said it is a very good topic because who would accept this topic, because it's a jargon, rather it's very important in the field of medical practice or the clinical practice. You may read something, you may have the knowledge, but then how to apply this, that in the patient management, that's very important. These things are very important that, as you know, that I think it's in the health and allied sciences somewhere in the medical field, they should read also genetics, because basic genetics, because no two individuals are same, they are genetically different. So that same treatment cannot be applied for everybody. Maybe the disease is same, but it differs from person to person and their response will be different. because they are genetically different. And also, this index that medicine, if according to the body weight, the children and the adults and the old age people, but in case of the physiotherapy and all other the occupational therapy, it is many times it's the child and as well as the adult and all and the old person he will differ. But then there is also, if there is adult also, somebody's BMI is very low. So, for example, I give an example that if doctor advises some medicine, for example, antibiotics, 500 mg 3 times a day. TDS. But I say that it is not, you should not do the clinician, you should not be doctor. So it is then I know my body that it cannot be that I can take 3 times 500 mg. It will be terrible stress from my body, from my body and from my physique and tolerating that dose. So I make it 10 dose. If it is in the morning and evening. So it is just I am giving a simple example. Then you should not do yourself. But you should express and the clinician should understand that this dose or this type of physiotherapeutic approach, maybe it is tough, but then if it is a very old person's, 80-year person or a very young children, so you have to you say that according to the persons you should that. That is customize that. And that you are not debating. But then one important thing, what is the main theme of this workshop or the symposium is that evidence based. So how that evidence is that you have the knowledge, but then how that evidence based. So which is the clinical knowledge is already established. But then you have to customize according to the patients and you have to understand or have the history of the patients and then you apply that type of what is applicable to that patient. It should not be stressful to these patients. But I know it is the treatment which is given for betterment of the patient and their about the cure of this disease or management of the disease. But this evidence based that you can have there is a guidance, there are regulations that how do you may have read that this is the things we have to utilize, but if you improvise something or if you develop something, you should not, that should be evidence based. Before you apply to the patient, you should practice because of the fact that physiotherapy and occupational therapy has a lot of opportunity that the clinician can improvise. For example, in an ethical meeting, it was proposed some PhD program that it is, of course, it is a research, that before you do that, then there is an opportunity for research and innovation. So you can do a lot of in case of the physiotherapy and occupational therapy that you can develop some guidelines or some the way of treatment, the procedure, and you can develop your own procedure and then but then before then we need to do some research or some to that create evidence so that you can propose or publish that evidence and that evidence you can show that what you are doing that is evidence based, that there is a proof of it. So this is you can get from the PubMed or Medline or national guidelines, medical guidelines or the up-to-date point of care tools also you should know time to time if there is any new tools are coming. And then for example yesterday the CME we got this Dr. Olga Bogosova. So this she talked about and there are three good people but they were not able to speak English. So the translator was there. They were speaking in Russian language, and that was the first experience that Russian language is being translated in English. So, but they are experts in the field. So there is a new technique has come, electromagnetic. She is here. So welcome once again today, Dr. Olga. So Thank you very much for participating today. Yes, you are here to deliver a lecture. So this is a new approach. So it is also to be, but this is, they have given the machine and we are creating the evidence based, and then it can go to the clinic for the applications. So this is very important that the how that one should go systematically. We should develop the statements and based on the rigorous and the transparent way. You should review the medical records or the medical literature, and then you find that whether that such thing can be practiced. So this is very important, that systematic review, grading of the evidence, and then the multidisciplinary approach and focus outcomes. Main aim to improve the patient care and safety. That's the most important thing. This CAHO, which is called the Consortium of the Accredited Healthcare Organization, CAHO. We are the member of the, Amity is member of the CAHO. Dr. Agarwal, Professor Agarwal comes, he's a great medical man, is the president of that, and we are member of that. And we time to time organize. And this year end in September, we have a big meeting on that. Time to time in a year, 2-3 meetings we organize. So this is the CAHO's principle also, that the patient safety and the quality treatment is the most important thing. The patient safety and the proper or accredited or the evidence-based the decision making, the treatment decision making, what type of decision to be given. So evidence-based decision making means what is called is that it is a consent, or knowingly you take a decision that I know this principle and evidence, and knowingly you take the decision that this person need this type of treatment, and that is called evidence-based. And there the most important is that to focus on the outcomes. The main aim is to improve the patient care and safety. The two things. Patient care is right. The treatment you should bring to the amelioration to the disease condition, but at the same time, safety of the patients. So you give the treatment such a way that he or she, the patient become more sick. Then it is not a treatment, or it happens something wrong to the patients. So that is to be careful. That depends on the clinicians or the doctors, because the others are laymen, even they are as educated, high educated like IAS or anything, they are medically ignorant. So they consider doctors or the clinician as the God. So you have to decide what you have to do, and that is up to you. So that is why they do not know, and leave it to you, the person or the patient, to your care, and you should do the best, and you should have that responsibility to act in a proper way, that it should be betterment of the patient and safety of the patient is most important. So main theme and their main crux of the matter is this, that you do whatever treatment, that treatment procedure or the methodology or the clinical procedure should be evidence-based, or for that if it is nothing known, you can do research and establish the evidence or the proof of that, proof of concept, and then you can go ahead, and then you need to publish that also. Otherwise, they will say that you have done, what type of research you have done, we do not know. So that is very important. So this is what all the students, you must remember that what you are learning, what you are applying to a patient, you should understand. You are told by the teacher and all, you go to the clinic, the clinic, and you start practicing or doing that. But you should understand, you should know, read extra while or extra reading, so that you understand, go to the very basic principle. Every literature is available. And nowadays, because of the digital age, you have the mobile phone, you can immediately open your phone and go to the ask the Googles. The Googles will answer every questions, and you can accordingly take a decision that what is to be done and what is the basic principle involved, what are the organs involved, and how that is affected, and this will give the impression. So I wish you all the best with this one-day symposium, and it is a continuous. I don't think that tomorrow's symposium is, the conclave is not going to be, it will be sometime later. So it's good, all the best. And all the speakers, I didn't take the name, Dr. Sina. He will be on Professor Dr. Sina from Punjab University, Patiala. Welcome to you for the online that you will not be able to come physically. So welcome to you for your lecture on the online. We look forward to it. And Dr. Madhusudan Pan, who is not able to attend this, being in Delhi itself. So Neeraj Kumar Misra ji, so you are here already. So, and then the Olga Vodosova, so she is already here and the online she will be there. And then Prasul Priya Nayak from AIMS Jodhpur, welcome to this symposium. And Vodosova Mohanty, Vodosova Mohanty, so I know her. She is from Deen Dayal Upadhyay Institute of Physically Handicapped. So Delhi University. So she is already with PhD from here. You completed? Yes. Submitted. So welcome Dr. Madhuchanda to this symposium. Afternoon. Thank you very much. All the best.
Thank you so much, sir. We are truly inspired. We now have the honor of inviting Professor Dr. Chandradeep Tandon, sir, Additional Pro Vice Chancellor, Research and Dean of Biosciences and Biotechnology at Amity University, to address this gathering. Sir, we most respectfully invite you.
Thank you so much. Once again, on behalf of our most respected Honorable President Sir Dr. Shokesh Chauhanji, our Honorable Chancellor Dr. Atul Chauhan, respected Vice Chancellor Dr. Parvinder Shukla, and on behalf, I once again welcome all of you, dignitaries on the stage, off the stage, and also online. At the outset, I must appreciate this very important topic. Jaswanta ji, you must have done lots of research to come up with this topic. So this is so important, bridging the gap from clinical expertise to evidence-based practice. All the students who are sitting here, I know you are coming, attending your classes, and also you have managed it very well. Thanks to all your faculty members, they coordinated so well. Students, I can see students from, I just asked Vaswanta ji, you are from MPT and DPT, and also few scholars are there also. Scholars, if anyone scholars there, can you raise your hand? Great, great. PhD scholars, yeah. Great, great. Absolutely. Very wonderful. See, students, you must be wondering, life is a continual process of learning, so all of us are students. That's why Dr. Harish Prakash raised his hand. So I also raise my hand for that. See, students, I know you must be busy. Your perhaps your attention is on your mobile phones. But these kinds of, these symposiums are very, very important for each one of you. You are in a very good field, very professional field. Recently, I attended as one of the panelists, owing to I happen to be a governing body member of Ministry of AUUP for CCRH, Concept of Research in Homeopathy. There also a lot of debate took place on this particular topic. Homeopathic system. In fact, this evidence-based, the topic of this particular symposium, evidence-based practice, our scientific validation is a very, very important part component, and it cuts across all systems of medicine, not only allopathic, but whole Ayush. You know the full form of Ayush students who are sitting here? Ayurveda, Unani, Yoga, Unani, Siddha, and homeopathy. So there also, this is the most topic, and everyone discussing on the scientific validation of the various practices or the system of medicine which doctors are following, and patients have to follow whatever doctors say. But for patients, doctors play a very important role. In fact, doctors are like gods to all the patients. But it is our right also, whether we are patients or whether it's from doctor's side or we are scientists, that there should be a scientific validation which all is done, because seeing is believing. And today science has made so many advancements. We have so many worthy scientists here also. Amongst us, Dr. B. Prakash is a very eminent scientist. Harish Prakash is sitting here, जो भी हाथ खड़ा कर रहे थे. He is a brilliant scientist in his research. He is heading the MIT Center for Transnational Research and the field of TB. He is doing a marvelous research. So we also have with us Mr. Bantaji, Dr. Navid, all these are very experienced person. Dr. Neeraj has come and Dr. Olga and Dr. Das was sharing yesterday also. She delivered lecture and today also she will be here. And Dr. Naik is there. And there are lots of, the whole, the second half specifically the expert session is on innovations in rehabilitation and therapeutic interventions, where they are going to be not only there's a lecture, but it would be very good if it becomes interactive session so that everyone can interact and benefit from this. So without much ado, I don't want to stand between all of you and the very important speakers. I wish that this symposium really enlightens everyone and the topic very important topic or the theme. Actually, it was disseminated by each one of us who is here. With this, thank you so much.
Thank you, sir. Your address truly highlights the importance of connecting clinical knowledge with evidence based practice. It is now my proud privilege to felicitate our esteemed guest, whose presence truly elevates this occasion. As a token of our gratitude and respect, I request all the dignitaries present on the dais to please felicitate Dr. Neeraj Mishra, HOD Occupational Therapy at JB Pant Hospital, New Delhi. Sir, we truly honor your remarkable contribution in the field of healthcare and rehabilitation. Moving forward, we will be connecting online with Dr. Olga Bodasova, medical advisor at Elamed, Russia, for the expert session on digital health and allied advances. Dr. Bodasova's international perspective on medical technology and rehabilitation is a tremendous asset to the symposium. Dr. Bodasova, we are delighted to have you here with us again. Let's start.
Thank you. Thank you. Hello, dear colleagues. Let me share Russian experience based on evidence-proved application. You understand that now low-intensity PMF is really one of the trend in physiotherapy. And let's discuss some clinical studies and our experience. For example, it was proved and it is clinical evidence that shows that PMF can be effective for different types of arthritis, osteoarthritis. The results of clinical studies proved that PMF not only demonstrated analgesic and anti-inflammatory effects, but mostly important, it has structure modifying effects. It helped to maintain cartilage thickness and control further degeneration. It is a great news for patients suffering from osteoarthritis, as it not only provides the pain relief, but also improve joint health. That's why we use very wide in our clinics pulsed electromagnetic field therapy for example, for different types of arthritis. Knee osteoarthritis is the leader of this problem. Other clinical studies confirm efficacy and safety of PMF as the method of non-drug therapy for acute and subacute non-specific back pain, because it's possible to achieve more effective pain control, restore function, and reduce pain. We need we can decrease the amount of NSAID when we use PMF in treatment of our patients. Let's move on to talk about PMF effects of nervous system. For example, one of the big problem is the post-stroke rehabilitation, and it was clinical study confirmed that A low-frequency transcranial magnetic stimulation can help patients with ischemic stroke to recover faster because it promotes regression of motor disorders and depression. It reduces the level of anxiety, improves daily activity of our patients. Another important topic to talk about is cognitive impairment. It is about transcranial magnetic stimulation, of course, and we discuss low intensity, low frequency magnetic stimulation. The parameters are the intensity is from 1 till 100 millitesla. The frequency is from 1 to 100 Hertz. As about cognitive impairment, PMF helps significantly improvement cognitive functions such as memory, attention in patients with different types of cognitive impairment. We improve the sleep quality, reduce the depression and anxiety, and make the life of our patient better. Migraine is another common problem these days. Transcranial pulsed electromagnetic field therapy helps to reduce headache, reduce different types of migraine symptoms, and normalize the psycho-emotional state. Moving on, let's discuss effects of PMF on the respiratory system. We had situation with COVID-19, and after COVID pneumonia, we have different problems with lung functions. So PMF helps to increase vital capacity of lungs and chest excursion. It improves overall mobility of our patients and reduce the shortness of breath. We use PMF devices in Russian Federation to deal with such a problem like problems with lungs and breath deficit. The next topic is, of course, for example, insufficiency of vessels. We treat problems with vessels to make, to give a possibility for our patients have a good blood circulation, and not circulation in big vessels, but even in little vessels. We can improve microcirculation when we use PMF devices. And when we speak about microcirculation, it is good clinical experience to use PMF devices when we deal with, for example, diabetic polyneuropathy, because this is a problem of microcirculation and the level of glucose. But microcirculation is the main topic when we speak about the diabetic polyneuropathy problems. Just now, you know that the interest to PMF therapy is very high. We try to make different types of clinical study, and our experience in osteoarthritis, respiratory system, cognitive dysfunction, and so on are very interesting, and many doctors are interested in these topics. I wish you to understand the opportunities of PMF, to understand that PMF can help you to improve your clinical practice. It is the second line of therapy, but it's really good. And now I think that you all will agree that PMF is the promising method of treatment and rehabilitation of our patients. Thank you very much for your attention.
Thank you so much, Dr. Bodhisova, for yet another enriching and globally informing session. Your contribution to this symposium across both days has been truly remarkable. We are grateful and honored. Ladies and gentlemen, we will take a short break for tea. Please take this opportunity to refresh, network, and engage in conversations with our distinguished guests and fellow delegates. We request you all to please gather again after 15 minutes of tea break.
व्हाट्सएप में क्या इजी क्या रहेगा पेन ड्राइव पे लगाए आपसे व्हाट्सएप कर दीजिए व्हाट्सएप कर दूं हाँ फिर हम लोग मेल करेंगे
Innovations in rehabilitation and therapeutic interventions, a domain that is rapidly transforming patient care across the globe. We are honored to have leading voices in this field today with us. For the first session, we are privileged to welcome a distinguished academician joining us virtually today, Professor Dr. A.G.K. Sinha Sir from Punjabi University, Patiala. I request everybody to have a big round of applause for Sir. Sinha Sir's research and academic contribution in rehabilitation sciences are widely respected, and we are honored that he is joining us online to share his expertise. Over to you, sir.
Thank you. Thank you for inviting me to this hybrid conference, and it is really a pleasure to be with all of you. The topic on which I am asked to speak is innovation and research in allied healthcare. Now, when we talk about innovation, we mean something is created which has not existed before. Now, how does that is created? Can the innovation be created in a vacuum? It seldom does. Innovation is appreciated when it fulfills the need of the community, when it fulfills the need of the discipline. So, innovation does not happen in a vacuum. Now, if I look at the research, current research trends in the physiotherapy, especially in India, then most of our research is largely on collecting the evidence. This practice of evidence-based practice, I feel down the line, that it has really killed the spirit of research and innovation. We are trying to validate the things. We are trying to conduct random clinical trials. And we have not bothered to see if there is any case study, if there is any case series, if there is any other kind of observational studies and existing on that topic. And more importantly, does it really meet the requirement of the nation? For example, I will tell you, the whole country, the whole ecosystem is now working on making, rehabilitation robots. Now suppose if a robot is made, now will it really help our 1.2, 120 crore people when we are struggling with the unemployment and we don't have this? So that kind of thing we must consider. Now coming to the physiotherapy, when I talk about the need innovation, then three aspects of this whole thing comes into the mind. One is the diagnostic, another one is therapeutic, third one is the service delivery. Now each of the field, we have a lot of practical difficulties. Now one has to be very clear that in this era of fast developed science and technology, one person really cannot do the research. One person cannot bring about the revolution. Gone are the days when when Madame Curie sits and she discovered the radioactivity. Here research is a planned activity. And making an innovation essentially require bringing the expertise, bringing the best mind of the different fields to solve a given problem. I'll tell you one example. In physiotherapy, when we talk about this evidence-based or efficacy, or we talk about therapeutics, muscle strength, muscle force is one of the major parameter what we tend to improve. Okay. So we have a series of exercises and all our interventions. We know we have enough evidence that weak muscle produces that. Now, when we give the exercise program and all, how much the patient has improved? Do we have an objective parameter? Of course, dynamometer exists. You know, the isokinetic machine exists. The isometric machines also exist. Now, but at what cost? How many of the therapists in the clinical area have an access to these? So as a result, what happens? The information generated through these kind of research are specific to a given location, specific to a given circumstances. We have not thought about developing an easy tool for measuring the muscle force. Just 7-8 months ago, I went to attend a conference, an international conference on biomechanics in Navi Mumbai. And there, I had an interaction with a professor of IIT, and I was talking about him. You see, basically, force, we cannot measure the force, we can measure the effect of force, that is pull and push. Now, why it is so? Because all my life I have tried to develop something, cost effective thing by which I can measure the external rotator strength of the shoulder, internal rotation strength of the shoulder. Now, these are important parameters when I talk about the rehabilitation of an overhead athlete. We have the data from the isokinetic and all. Now, how to translate these data into the clinical practice? So I was just struggling to make it, and I knew it is basically the sensor work and the transducer work. Now, given the advantage what we have in the electronic communication and all these things, it is not a big deal. So I was asking the professor, why we are not working on that? Why don't you work on these things? The professor listened to me. Now, why he has listened to me? Because I was in his car and it was half an hour distance. So he had to listen to me. There was no other way. Then he replied to me, you see, this is a very simple problem. It does not attract, the intellect of the engineering people. And this is basically a second year or third year engineering product. And for me, for my problem, he offered a solution that if you happen to come to my institute, maybe I will make some people available and they can do the work for you. Okay. Then I said, it is not, maybe it is not a scientifically, challenging thing for you, but it has an immense commercial potential. If you can develop a device which comes under 10,000 and you can measure the most of the muscle forces and all, it will have a major marketing potential. He said, okay, we will look into this, that, but there will be no publication arising from this. Then our talk ended and we both seated on our chair, and similar to this lecture, which I am delivering online, there was another lecture from Uruguay. Uruguay is a North American country. And the researcher, he was describing that he developed a device. Now it is called a Dina Bank. You can search it on the net. It is just this much, a size of a pen. It contains the accelerometer, it contains the dynamometer, it contains the gyroscope. Okay, all these things what we have in our mobile. And then he connected it to a tab, a small tab, and he demonstrated the when you connect this shape of the device to a cord, it measures precisely the isotonic muscle force. And then he went on sharing, it took him about 10 years working with physiotherapist, working with kinesiologist, working with exercise physiologist, and then they have a proper research team for that, which had the electronic engineer and the component and everything. So then they come out with that, and as far as the publication is concerned, he was listing about 23 publications. And I was looking at the professor, and professor was looking at me, the same IIT professor who said it is a second year project. I told professor, you see, this is a mixed feeling. This paper gives me a mixed feeling. One, that a solution to our problem, our practical physiotherapy problem, which the researcher has himself described, the person from Uruguay, as the stethoscope to physiotherapist, Dinaba. And he was searching for, a startup from the India who can market it to this. And I said, it is one thing good, but then it is a matter of national shame for me. Now, why national shame for me? We in India, we can send our equipment to the China, to the moon. We can measure precisely the temperature, this, that, but we cannot translate it to the solving the mass, the problem of the people. So this is the basic problem with the innovation. This is the basic problem with the allied research. All these years, I feel we are sitting, each of our discipline are sitting in an ivory tower. We hardly interact with each other. And unless we interact, unless we bring out our need, the innovation will not take place, research would not be meaningful. Now let us take another case, service delivery. India is a diversified country. We have so many regimes for the cerebral palsy, for stroke, for multiple sclerosis, for Parkinsonism. We essentially know, the clinician knows that they require a long-term exercise intervention. And most of the people, they cannot follow it because of the cost. One visit to a physiotherapist takes so much of time, and accessibility is a problem. What about a person who is living in a remote area? It is not essentially, may not be essentially a poor person, but many people, they choose to live in the different areas. And then how to enhance this service delivery? We have with all these years, so many apps has been developed. The food delivery app, and all sort of apps are developed. We in Punjabi University Physiotherapy, one of my students, while working on this problem, he has developed an app for the multiple sclerosis. Now, what that app is? It basically lists the patient's symptoms and then suggests the exercises. Now, what involved the making of this app? It involved the intervention of a physiotherapist, a neurologist, to identify the patient needs. Then it involved the physiotherapist to select the exercise, to demonstrate the exercise, to decide the proper sequence. We prescribed bend the elbow. How many times? 10 times, 12 times. How many sets? We seldom prescribe that. So that prescription is there. Then came the multimedia people. There was a proper pre-production, post-production, production, shooting and all that. And after it has been done, then came the computer professional to design it in the app and then come this testing. So what I want to highlight in this short presentation is that think out of the box. Take a problem of the country and then start working on that in a systematic manner. China, just yesterday I was reading about this innovation. PhD is essentially, a thesis based thing. Throughout the world, we are required to write a thesis. China has come up with a proposal, or they are doing it, especially for the science and technology, that you develop a prototype, and if it is innovative, one of the criteria of the PhD evaluation is it is an innovation. It is a new knowledge, new information, new thing, new interpretation of the data, and anything which contribute to the vast sea of the knowledge. So they said, okay, no, there is no need of writing and all this. This writing takes a lot of time, and many people who can write, they cannot do, innovation, and those who innovate, they cannot do this writing thing. So they said, okay, what we will do, we will award the PhD work on the innovation prototype. Now, in India, this is something which we cannot imagine. Of course, I understand that writing is necessary because it develops the critical skills. And when we certify an individual for a PhD degree, we are not certifying his work. We are not only honoring his knowledge, what he has contributed to. We are also certifying that he has the ability to do the critical inquiry, and he has the ability to critically examine the information to establish that any innovation is new. Okay. Because just to say that this is new, it is not sufficient. We have to prove that, okay, this is new only. So in that situation, my only suggestion is, since all these years, the physiotherapy was not in a formal educational field. Now it has come in the organizational. And the institutions like Amity, where you have all the discipline under one campus, and you have a very, nice bureaucratic structures. I am given to understand that you collaborate among each other. So this multidisciplinary kind of things, where physiotherapists identify the need, translate it to the need, and then test the product developed, involve the people with the other departments, okay, and then develop a project. This is something, if it happens, then definitely we will go a long way in our research and innovation. Thank you for giving me the time. I think this is sufficient. If you have any query or any questions, I am open to that. Thank you.
Thank you so much, Professor Sinha, for that insightful presentation. We are grateful for your time and wisdom.
Thank you.
Thank you, sir. We now move to our next expert session. We are delighted to welcome Dr. Neeraj Mishra, Occupational Therapist, Department of Neurology, JIPMER, to address us today. Dr. Mishra's clinical leadership and hands-on expertise in occupational therapy bring an essential and practical perspective to today's discussion. Dr. Mishra, we warmly welcome you to the podium.
So first of all, I would like to convey my sincere thanks to the management of RMIT and the faculty members and to all the students who have come here so that I can just share my experiences about rehabilitation and the innovation. The best thing about this topic is that it talks about evidence-based practice. So, evidence in our day-to-day life, tell me, evidence in our day-to-day life. When you order food online from Zomato, what do you search for? Ratings, picture of the food, what other customers have said. When you are booking a hotel on Make My Trip, what do you search for? How it looks like, how people have given the reviews and the ratings. So evidence is nothing new to us, but When it comes to the clinical aspect of using it, then we are a bit reluctant at times. That is what this workshop tries to bring into you. See, imagine something, suppose samosa, and it will not come to the damage. Sometimes it could be from bad health, in an intensive care unit on a very critical patient. And that is something which does not have good evidence. What could be the damage? Someone could. So, as occupational therapists and physicians, venturing into unexplored arena or new arena can be done with confidence only when it is backed by sound clinical evidence. So, from and henceforth, make sure if you are trying to do something, trying to adopt a best practice from somewhere, ask a question. Is there an evidence for this? If your answer is confident, yes, think again before you actually go ahead. Kinds. Now, talking about habilitation and this, she's changed a lot over the years. What does that mean? This change? Change how right habilitation. See, if you it was just a passive therapy, some points. That's all. We were not testing what we are doing. We were sure of what it is about to do. But then, as medical science progressed, as imaging facilities progressed, see what you are about to do. And also, you are able to find the outcome of what you are about to do. This has been a game changer in meditation. Earlier, facility of imaging the brain. So you could just see brain as a structure. That's all. कि अच्छा ब्रेन है अगर उसमें कुछ स्ट्रक्चर में चेंज आ गया है ब्रेन सिकुड़ गया है किसी जगह पर कोई इन्फार्क्ट है तो यू कैन विजुअलाइज see brain as a structure and function together कि ब्रेन में जब करता है ऐसा होता है ब्रेन में जब सुनते हैं तो स्टिमुलेट होता है एंड देन exact of the brain exact pathways कि अगर हम मेमोरी पे काम कर रहे हैं स्टिमुलेट अगर हम किसी मोटर स्कूल पे काम कर रहे हैं तो वो स्टिमुलेट what they did allowed change their attention because you can see the action now rehabilitation. So from that this is a basic passive therapy now something which became first very oriented system. So that is now the technology to find out something, so we will use it for the best practice. And the new aspect is the exact brain imaging with artificial intelligence. Now in today's science and technology to help you out, and if your clinical skills are there, something should be called a precision neural map. Precision neural map means you know exactly function you want to achieve. So when we were saying hand function, now we can make it typically speech के लिए हम क्या कर सकते हैं? Not remain but now you can narrow down. I'll also tell you an example of how things are narrowed down and how we can exactly know. So sensory integration therapy, everyone has heard that word. For many years, the question mark whether sensory integration therapy actually change as measure it. Question initially. It said how to tell that okay, there something in the body which got changed. So there was a study called spaceship study, in which children who were having sensory integration issues, it was hypothesized that if you are in an anxious state, aroused state, your sympathetic system would be at a higher level and your parasympathetic system would be at a lower level. So what they did, they put the children on a chair which was rotating 20% vestibular input, and we checked the resting skin electric potential to measure the sympathetic response and the resting vagal tone to measure the parasympathetic response. You will be surprised that they will find the changes that happen. So from that date, there is a conclusive evidence that sensory integration में जो बाहर से देख रहे हैं, actually में there is a change that is happening at structure level, functional level, biochemical level. So such kind of evidence is possible today, and with such evidences, I'll give you one more example of that. Children, again, another way of finding example. So children with autism, resting salivary level cortisol was measured. Cortisol tells you how much aroused your system is. And then after giving them sensory integration therapy, again their salivary cortisol was measured, and it was found out that the cortisol level went drastically down, which again conclusively that whatever in terms of mood is affecting the sensory response. And when especially the students are from physiotherapy and occupational therapy, almost all of them physiotherapy and occupational therapy students. Physiology students, okay, yes, perfect. So I'll ask a question, I want an answer from you. Let's keep a bit interactive. Do you think anything or any sensation can change our movement also? What do you think? Or can you give an example of this? Can we have a volunteer from the students? Anyone? इंसान से मुर्गा नहीं है, सेफ है, आ सकते हैं क्या? सॉरी, sensory change response. So, Pratik, please stand there. आ जाइए वापस, सेंसरी रिस्पॉन्स देते हैं, मॉडल कैसे बदलते हैं? कैन यू स्पिन इन योर प्लेस फॉर 20 टाइम्स? करो, 1 2 3 faster, 4 5 6 7 8 stop and then अभी 8 में हालत. चलो, please sit down. Thank you. Why I did this was, see, I have not touched the patient yet. मैंने अभी कुछ हुआ भी नहीं है. मैं उसकी मोटर रिस्पॉन्स को चेंज कर पाया by giving what? A sensory input. So this is the amount of evidence that we require when we are planning any intervention. Just remember that. Irrespective of whatever fields you are, don't think, thank you so much. आपको चक्कर क्यों नहीं आ रहा? अभी सेटल हो जाएगा पेमेंट में. ठीक है? So with this, we will try and see that how we have tried to bypass certain things so that we can achieve the goal. ठीक है? That's it. फॉर एग्जाम्पल पार्किंसंस को यह मैंने थोड़ा इजी रहेगा, हम लोग सब देखते हैं डे टू डे में, और थोड़ा स्ट्रोक की भी बात करेंगे. जनरली पार्किंसन डिजीज में क्या होता है कि that gets affected. The internal mechanism that is controlling the movements, fine-tuning the movements gets affected. So what the patient will come with tremors, imbalance, astute posture, and the movement is slower than normal. There are many drugs which tries to change this. Initially what we were doing, अच्छा ठीक है, flexion extension कर लो, थोड़ा hand function कर लो, थोड़ा tangent कर लो. Was that sufficient? I told in the beginning. So when we will which moves this will control. And then again we thought, suppose करो मुझे यहाँ से उस कुर्सी पर जाना है, मेरे बीच में खाली कुर्सी वहां जाके बैठना है. So that is the brain, and I have to follow this pathway. But this pathway is broken. How do I reach there? तो कैसे पहुंचूंगा वहां तक? इधर से चला जाऊंगा. तो क्या बोलते हैं एक्सटर्नल क्यू. एक्सटर्नल क्यू सेंसरी कि अगर हम एक सेंसरी को भेजना शुरू कर दें, उसका रास्ता दूसरा है, मतलब इनका ये रास्ता था सेंसरी का ये, और सिमिलर एरिया में ऐसा देखा गया कि bypass the damage deriving circuits through strategic sensory stimulation. Now, what kinds of sensation we can get? It can be a visual stimuli, it can be an auditory stimuli, it can be a somatosensory perception, vibration stimulus. What it does, so instead of asking the patient to step करो, थोड़ा आगे चलो, हमने उसको visual marker दे दिया. Step on this marker. So we have given a different spatial information to the patient, and what it did, it was found to take away freezing. Auditory में हमने देखा, it's regular. Sound was guiding the speed of the. So again, so हमने क्या किया? Tactile feedback, and what happened? The response again changed. So what we did, another pathway, sensations which were intact, and achieve the similar response. Let's see how I do it. So auditory cueing. This client is having a problem of wheezing. You can hear a tuck 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 sound is going in the background. But this sound controls the speed at which this movement will be on. Then increase the speed, you can decrease the speed. Starting point has to be 10% of the existing speed. Under one. Then you can do auditory. See, I am giving you auditory command. Stop. Okay. Stop again. Turn to one side. Then इधर आ जाइए. Turn to another side. So what happens? Jay. Improves the balance of the. You can see how much tremors there, how much difficulty it was having. But by modulating the auditory responses, we are able to achieve movements in the sky. And how it has helped? So research says that almost there is a 30% increase in the step length. The speed of walking also improves. And freezing, which is a major problem for the students who are first, second year students, I want to say. Parkinson's patient में क्या होता है, चलते चलते उनका ऐसा लगता है पैर चिपक गया जमीन पर, वो बोलेंगे चला ही नहीं जा रहा मैं. That freezing can be controlled by using a very simple tapping sound in background auditory commands. Okay. Next, visual cueing. Another sensation we have used. A simple marking, a laser torch, a piece of wood displayed. Step कहाँ पर रखना है? So just by changing the way that information was given, you are able to change the. See how now this person, because he got so there is a laser line. So every time he steps, that laser line goes ahead of him, so he knows where to step upon. Another step, again he will put the wagon forward, he has another guideline. So like that you can use technology, very simple, very cost effective, but you can improve the clinical picture of the client. Somatosensory vibration. There is a vibration device that is on the shin of the patient. So every time he is about to take a step, there is a vibration going on the shin, and that prompts the patient to step ahead. And it has been used for a very nice effect in balance training and coordination programs. So what are the advantages of external cueing? First, there is no specific medication required to do this. Second, it is a cost-effective solution, does not require too much of extraordinary or fancy hardware or software. It can be implemented easily and best side effects. So next time you come across a patient with freezing, try this method. It works like this. It works with wonders. Another aspect that has changed in rehabilitation, advance in technology, is the concept of mirror neurons. क्लास में अक्सर ऐसा देखने को मिलते हैं कि अगर एक किसी को ऐसे हुआ तो बाकी क्लास क्या करती है? What happens? इसका कंसेप्ट similar area of the group was stimulated. ऐसा रियल में आपने कभी कभी महसूस किया क्या? कहाँ पर? Can anyone give सबसे have you seen cricketers? जब जब उनकी बैटिंग आने वाली लगाउट में होते हैं, most of them are doing this. हवा में ऐसे ऐसे कर रहे हैं, हवा में ऐसे ऐसे कर रहे हैं. What benefit is it adding to them? There is no that, there is no simulating that that will happen well. So by doing a similar area of the brain, how it is contributed by this. So you can see this is the scan of the brain which was taken when an executed teaching task was done. So I had to share this mic. I had to observe my hand reaching this mic, and I also had to imagine reaching for this mic. Similar areas, almost similar areas are done. So how will it benefit us? When your and actual movements, this condition this capacity to imagine, he will be still similar. That's now. So about three different types of intervention in neural rehabilitation. One is intervention, second is action observation, and the third is error therapy. Alright, we'll talk about this action observation. About first, imagination should be from different perspectives. I'll tell you about that. And imagination should be done at the same speed at which the real action has been done. Can we from आ जाइए, बहुत मुश्किल टास्क चैप्टर है. मैम आप यहाँ पे खड़े हो जाइए, ठीक है. So first we will see a task. So I will tell her to go ahead, pick up this mic, take it back and put it on the chair, and let's see how much time she will take. Are you not imagining? Alright, that is going to follow. So she took almost 8 seconds to do this. That means now then on the chair. Close your eyes, imagine, and when you're done, just let me know. Okay? Start. Six seconds, 5 seconds. What happened? Imagine at a very different speed than the actual action will take. If this happens, then the same event can't get stimulated. So when you जब चल के सोचने में चलती कदम से जा रही हूँ, जब आपने बाइक उठाई है, रेस कर लेना, फिर जब वापस चेयर तक पहुंच जाओगे तो हैंड रेज करना रखने के बाद। जैसे मतलब इमेजिन कि आपने सोचा आपने माइक तक पहुंच गई तो ऐसे कर देना, और फिर आपको लगा पलट के आप चेयर तक चली गई तो फिर हैंड रेज करना, ठीक है। एंड काउंट द स्टेप्स, यू हैव ऑलमोस्ट 4-5 steps here and almost 10-12 steps here. Can we start? Let's start. Reach the mic. All right. How many seconds was it? 9 seconds. Almost similar. Thank you. Similar actual performance that I want. This is called mental isochrony. It means that your speed of imagination and your speed of actual of a movement, if it is matched together, similar area of the brain starts to get stimulated. And this is the concept behind motor imagery. So if you see go to the practice, you can achieve again results based upon what you want to practice. It could be an upper limb movement, it could be a lower limb movement, it could be a ADM task, it could be a gait and balance task. How do you have to imagine? In three aspects. One is a visual, that you are visualizing like she was doing as a key person. Second is a kinesthetic. She has to feel the movements. That each and every step of the now I lifted it up and now I am pressing. And third is we add auditory guidance to this. कि अच्छा बात चलो 3 कदम आगे, अच्छा माइक उठा लिया, अब 4 कदम चलते जाओ और बंद करके वहां रख दो. Three kinds of imagery, then you will achieve the exact desired response. Similar aspect again of making the movements, an example of mirror therapy. What happens? In which one side of the body is paralyzed, what is done is the affected side, suppose this side was paralyzed, for this the left hand of the patient is paralyzed, it is hidden from his view. And the right hand, which is the normal hand, is doing the functions, but seeing those functions while watching himself in the mirror. So when you see in the mirror, you see the reverse side. So the brain thinks that the left side is actually doing that. That is how the affected side is doing. And mirror perception and processing of movement and pain. And again, it has found to do with thinking and neural tasks. There is another concept of task training. Our brains are made to work at a time. And with practice, you can improve. That's it. When you are learning how to drive a scooter, how do you drive in the first, let's say, 15 days? Like this. 6 महीने बाद क्या होता है? 6 महीने बाद एक हाथ में फोन है, सैंडविच है, इससे गाड़ी भी चल रही है, बात भी चल रही है, कुछ लोग मेकअप भी कर लेते हैं साथ साथ. And still the car is doing fine. How does that happen? Multitasking. So it is found that when you are together, then it is to improve. That is the concept of task training. So when you take the machine to task together, multitask कर लो और साथ में combination task, कुछ याद करने का, कुछ number, solve for cities of the month, ऐसे reverse में बोलने के लिए. Let's see what happened. See an example of this. What this girl is doing? She is doing a motor task while walking और साथ ही साथ में क्या कर रही है वो months of the year के नाम reverse में बोल रही है. So when she is doing a motor task at the same time उसका cognition भी काम कर रहा है. Benefit, it has been found to the gait and balance. If used for hand function, it has been found to improve the hand function in clients also. 1 second. Another aspect is, as I told you, now. So you can learn the activities which are not possible to do in the real world, or at times which are not safe to do in the real world. For example, if you have a client having significant balance and cognitive impairment, and we want him to eventually be trained to cross the road by himself. Where will we train him? On the road. It can be because नोएडा में भी सबसे ज्यादा डेंजरस है. 8 तरफ से गाड़ी आ सकती है नोएडा में एक ही जगह पे. तो हम सब कि अगर आदमी 1 सेकंड में टाइम पर तो हो सकता है 4-5 गाड़ियां आपको. So for such situations, there is something called simulation. Simulation means you create an environment which is similar to the natural environment, and then you make the client practice into it. And for that, now we have something called virtual reality and augmented reality. What it does, it makes the client he is on the road trying to cross, so the cars will be coming in from different directions at different speeds, and then he has to adjust his speed. Or if he has to go for a hand function, they will be looking at some object, picking up and putting it back. So such kind of practice now can be done in a environment which is called virtual and augmented reality. So training for a hand function and all in the form of gamification. So simple games are made there, this involvement is there, and they can very easily, by tracking of the movements, you can make them be functional tasks. Again, if you want to find the task, you can simulate very simple activities like some shopping in a mall, scripting without reality. So the patient just don't actually see the screen. And then every time there is a feedback to correct him. If you want to do the extremity, see, then combination. So all these things can be incorporated into the therapy. Just 1 second. So in talking solutions, what happens? There is lots of tremor into the hands, which makes them very debilitating. They are not able to hold on to the glass, able to do something, and because it keeps moving, so just fatigue and pain on the shoulder and all. How can you stop it immediately? This in one go. There is external stabilization. The external stabilization of the limb, it will stop for some time. It will stop for some time. It won't stop forever. It will stop for some time. So if you can do that, the patient gets a respite from the tremor and the muscles get to relax for a while. Okay, and at the same time, if you add a bit of relaxation and breathing exercises, again it has been found to relax the patient, his anxiety levels become low, the tremor goes down. Negative cough and medicines have been used but have not been found to be very effective in the long run. So as you can see in this video, for the tremor that it has initially. See, almost stop for a while. So we were momentarily nice. Next. Tremors and to improve functionality. Two different types of devices are used. One is orthotic device. What it does, it assesses the tremor of the hand in real time and responds with more precise counter movements. I'll give you an example. Suppose my hand is trembling like this. So if I have a suppose the pen has a inbuilt mechanism that in the reverse direction it will start spinning when my hand goes like this. So then what happens? Then that the counter mechanism will make the tremor faster. That is how the devices are work on. It's also physics which help you counteract by giving a reverse stimulation. The another one is, see what semi-active orthotics, what they do? They use mechanical principle of inertia basically to dampen the tremor. So suppose if this device had something at the beginning, so even if my hand shakes like this won't move. So if I can dampen the tremor into this device, then what happens? Again the function will be present. So these two types of devices have been used for controlling the tremor in connecting functions. And what research says that functions there are almost 30% improvement in the gait. The statement last training. 50% and that's a big number. Patients are mostly getting the because of this reason. Just by use of external modified and 65% patients said they had a better satisfaction and behavioral independence after the use of adaptive devices, cognitive and executive functioning with the use of real-time and virtual reality. What are the challenges? Now, external key I said is very effective, but quickly it diminishes. So you have to keep on changing the cues. पहले auditory दिया, फिर कभी visual दे दिया, कभी perceptive होगा. If you keep on changing, then the effect will continue. There will be very nicely, some will respond slowly, so you have to keep on evaluating the methods. And sometimes what happens is there is a cognitive decline, then there will be skill and motor imagery. So accordingly, again, you have to find out the other method. And what are the developments which are because now smart glasses and AR, I have shown you. Devices trainers and virtual reality rehabilitation. So technology is adding to us, and what technology is doing, it is like the icing on the cake. So the cake, base of the cake is the total skill, and technology is that icing. Add them in correct proportion, and you will get a good amount of improvement. That is the goal finally. Personalize the approach, wherein every individual side technological advances has to be integrated into the therapy as and when it is required. Holistic care, remember, no movement is important. And finally, add all these things. So, any questions?
So, sir, that was a very important presentation and give insights into the practice and promise of occupational therapy into modern rehabilitation. We are truly grateful for your presence and contribution today. I would now request everybody to please proceed for lunch and we can meet here at around 2 p.m. Thank you so much. Our next session brings us the voice of national academic and scientific leadership. Joining us online, we are deeply honored to welcome Professor Dr. Prasun P. Nayak from AIIMS Jaipur and the President of Physiological Society of India for his expert session on the topic Future of Health, Harnessing Technology for a Proactive Global Future. Professor Nayak's outstanding contribution to physiology, preventive care, and public health research are nationally recognized. We are privileged that he is taking his time to address this symposium today. Professor Nayak, we warmly welcome you to the Allied Health Research Symposium. Over to you, sir.
Yes. Good afternoon, everyone. Thank you very much for giving me this opportunity. I express my sincere thanks to the organizing committee of this CME and this program. I am grateful to the Amity University, particularly Dr. Sudeshna, for inviting me. I think we'll go for sharing things. Yeah, can anyone please confirm that my full screen is shared?
Yes, sir.
Okay. So, with great pleasure, I was listening few of the things not followed properly, and it's a good initiative, very great, good initiative to uh, make the students aware about this program. The topic is good: digital health, preventive care, and public health advances. What I have planned is the technology, to harness the technology already available for a proactive global future. And for that, I have thought that the maybe a short and sweet title of the talk would be Future of Health. Before I initiate, I want to put disclaimer that there is no financial involvement and no other obligation involved in this process. And this lecture is intended it's not a lecture that way. However, this presentation is intended for educational and information purpose only. There are some names, some company logos might be there. Those are, there is no malified intention to use those in other ways. So, as we see, as we move through 2026, the healthcare landscape is undergoing a fundamental transformation. It's we are shifting from a reactive sick care mechanism, sick care system, to a proactive healthcare system. So it's a monumental shift where we are lot dependent on the data. We are depending on the digital health nowadays, where technology is integrated into every touch point of the patient journey. Nowadays, we go for online appointment for the patients, and those appointments, that technology and availability of the doctor, availability of the ambulance, availability of the healthcare support system, all are is part of digital health. However, this part is seek oriented. It's a need based. When the person is facing some problem in their health, having some health issue, then only they are seeking for these things. Can we have a uh, proactive mechanism so that we can have a preventive care, so that we can intervene before the disease manifest or disease escalate? Even if we know, like many of us, we are suffering, or our neighbors, our relatives, our family members, they are suffering from some type of chronic health problems. So can we monitor, and at the same time, can we make it to public, scaling innovations to protect entire population? There is a question of surveillance. Can it be a local surveillance? Can it be a mid-level can be a state level, can be a national, or why not global? So when we are going proactive, there is every possibility that we can make a fundamental transformation of our thought process, how to go for the health. Not necessarily, we only think that there is a need of health when there is a problem. We can think of that the health can be beforehand we can have a preventive or awareness, advanced awareness system so that we can have a better healthcare in future. In this context, artificial intelligence has come very handy, and we see that many cases of our health sector, many places there is AI. So starting with, if we can start with AI enabled diagnostics, it's a real time detection of say heart diseases or even colon polyps. Like it's a range I have mentioned where we can uh, reduce the missed diagnosis to a significant level. At the same time, we have nowadays, with the advent of invention and the new technologies, or even better, we can say it's a new algorithms which can a simple signal can be processed. So we can have medical grade wearables. Till now, it was supplementing. Now we can think of, we can rely upon, and we can depend on the medical grade wearables where condition specific devices can be there to identify. We know, all of us, we know now the mobile phone handsets are, if there is a snatching of handset get blocked, get stopped. Similarly, we can have for elderly, if there is a fall, if there is a abrupt change in pressure or abrupt change in heart rate, abrupt change in respiratory rate, abrupt change in EEG, abrupt change in say particular area blood flow, that can be monitored. So we need an enable to continuous monitoring with very importantly the clinical grade accuracy is important. With all these things, diagnostics, patient has to reach there, wearables can reach to patient, but can we link these two things together? One side diagnose setup, which is AI, which can help us to make things better if the patient visiting us. Other side, we are preparing a setup where, not setup, it's a home ground where the instruments reached to the patient and we are communicating between these two medical grade variables and diagnosis. It is being communicated, but who will communicate these things? So there comes the telemedicine. We need a platform, telemedicine platform, which will take the primary inputs and process them to make flags, something like say we can have a green flag, okay, everything going great, can have orange flag, can have yellow flag, can have red flag, something like that, so that we can increase the accessibility and optimize the availability of clinical resources as well as making them available. The AI-driven diagnostics that it include two special area. One is predictive. Like nowadays, models are being developed, regression analysis are going on, so that we are getting, we are depending on big data. We are producing plenty of data, and then we are taking those data towards a direction so that we don't have problem to identify beforehand the problems before it occurs, so that before years before, if not 10 years, maybe 1 year, maybe 6 months, maybe a month, maybe a day, that will help a plenty of patients. That we know in medical we say talk about the golden hour, that first 4 hours, first 2 hours may be crucial. Now, if I know there is a chance, we can have a diagnosis, a plan how to handle that. So it's a not a reality yet, but to some extent we can think of, and we are going ahead with the predictive analytics. At the same time, other side of the diagnostics, where when there is imagings are available, we can go more accurate and fatigue free imaging processing of the radiological images, pathological images, which is like the moment we say big data, it is like millions of data being produced in India, particularly technical staffs, our health setup staffs, they are producing, they are generating data, but those data need to be processed, and humanly it is almost impossible. So that where we need a mechanism, advanced imaging could be helpful in this case. So AI can help us in both cases, predictive as well as in case of when the image is at hand. Other side, remote patient monitoring. We have plenty of, already I have mentioned the medical grade variables. These are like Internet of Things. They are the sensors, and they facilitate a 24/7 health surveillance. A real-time data can be streamed, enables immediate clinical response to if there is an anomaly. If things are going smooth, fine, fantastic, nothing wrong with that. But in case there is an anomaly, to identify that anomaly, that also we need to have somebody to look after. It's not possible by the patient to identify. So if there is a nominal changes in the baseline, nominal changes in the range, within the range, or maybe from the healthy range to like upward or downward range, then it can be detected, and that continuous care, the continuous monitoring is required for this remote patient monitoring. That will be helpful for maintaining utilizing the future ready health setup what we are already having. In this case, we have telemedicine came handy. It's not like really what we think telemedicine, over phone discussion, like we can talk to our colleagues, talk to our friends, talk to a known doctor, okay, I am having this, shall I take this medicine or that medicine? It's not like that. It's the second level. Telemedicine 2, I just named, I don't know whether it is correct. So that there is a possibility of virtual work, managing acute conditions safely within the home environment using biometric integration, where either self or a help, both can give the initial benefit of healthcare setup to the patient, so that we can save life, we can save the cost, save the morbidities, we can reduce the morbidity of the patient. At the same time, if this setup is ready, this once someone is handy with this setup, he or she, they need not to wait for a particular patient, particular expert, a global expertise. I mean to say, not necessarily worldwide. What I mean to say, global expertise mean it's something like anyone available at that range. Something like, when we dial 100 to the, for police, the control room says whoever available in the that region patrolling, they can come into handy. Similarly, we can initiate a concept where I have initiated a red flag. I am a patient. I understood my wearable given a red flag, so that anybody around me can help me, can save me with my life or cost or morbidity. Now, for that, what we need? A platform, so that the data flow can be ensured between the patient, primary care, as well as special experts. So we need a high level data connectivity, internet connectivity, so that we can monitor continuously. Like in case we are depending on a telemedicine system, and doctor or the expert is suggesting something, and in between the internet is disconnected, the patient is in middle of something, and the helping person, or the self patient himself or herself, they are in jeopardy, they are jeopardized, like I don't know what to do. I have not taken the step to go towards the physical setup. I have depended on telemedicine, and telemedicine teached me. So we need to have an ecosystem where there will be backup, that if this is not working, something will immediately take over, so that things remain continuous. Now coming to a little different part, which is relatively less talked, yet maybe within few years it will be more. Instead of going into precision medicine, are we thinking of precision preventive care? Like that same concept, one size fits all, from there we are moving towards a personalized prediction, personalized prevention, personalized healthcare, which is already to some extent with the ascent of CRISPR, or we are going into personalized treatment part. But is it possible that we know each other, we have a digital, or say genetic unique ID, genetic unique concept, unique health care evaluation, so that my requirement wise I can take care of myself. It can be personalized risk assessment, as I have mentioned in the number one, personalized risk assessment, which will be depending on already what I have mentioned, AI, as well as the geological area, the geological circumstances where I am living. If I am moving from one place to another, moving by my living, by habitat I am changing, then I should have some different aspect, genetic as well as epigenetic evaluation of risk assessment, and this may likely to improve the disease detection process with better precision, with high precision level, and then we can have a targeted prevention strategies. Maybe we can have a classified system, like if we can have some point wise tick system, that if out of 10 points, if you are matching with these 5 things, then you should go with this type of particular type of prevention strategy. Or if you are going with 6 but not all those 5, some other 6, then you should think of this, so that there is something like awareness about myself, awareness about the available prevention strategies, and evaluation with what I should say, it's something like acknowledged evaluation of prevention strategies, prevention possibility, and let me decide what type of, like the way we choose for our health insurance, same way we can think of a prevention strategies, what is like a targeted myself or my family or the locality or this area, and this I expect this will give us a long term outcomes, improved outcomes in long term, and this will work efficiently because it is actually a prelude for the targeted precision healthcare. Preventive care may be grouped or stratified in locality wise, in family wise, in some particular gene wise, and then we can have a ready made to some extent, maybe half ready or quarter ready level of precision healthcare. In case of personalized medicine, what is the final aim for us? We are always looking forward the targeted medicine, targeted gene therapy. We must have a tailored lifestyle interventions where physiologists and the other health support staffs, they are very important in managing these tailored lifestyle intervention and tailored medical intervention. These two should come together so that I can have the better life. Nowadays, we are listening many casualties with young age. Like sometimes we doctors they are in shock. Like how come this early age this type of disease? Like age barrier is like slowly becoming faded day by day. The things are getting complicated as we used to think like okay this is old age disease, this is like young can should not be, but nowadays it's coming. Where is the problem? Is there a chance of mismatch between the two things? So we should have a level of like integration between the lifestyle interventions which must be personalized and the medical intervention that is also personalized. Both together we can have a better life or better health care setup. In case of personalized medicine, we have few specific things like genomics obviously and epigenomics. In the then optimization, all the genomic, when you have the in medical and lifestyle interventions according to your genetic profile here, it's a very unique genetic profile, so your tailoring of those things also will be unique. But even if it is in the same family, same genetic makeup, not necessarily the same way it is role of epigenetics, as well as there are some optimization we need in the pharmacological intervention as well as lifestyle intervention. At the same time, we as we go with the early detection of hereditary problem, sometimes of like say very maybe sci-fi, it may appear sci-fi, but biohacking is no more a big like no more far away thing. All we are very good things we have mentioned about the digital health. We could see the public say what we call the openness of digital health. But if we see the other side, this open public digital health might have some problem. Number one is the data piracy. Nowadays, we know that things are being pirated, things are being hacked. So there is every possibility that it may be hacked. At the same time, like earlier we used to be stuck with a particular SIM card and the network. Then came the portability. Similarly, we should have some interoperability from one. If it is a national setup, fantastic. But if it is a private setup and that private setup has the all digital records, that digital records must be accessible and freely with accountability with the other players as well, so that the person, the patient, if required, patient if choose to move from one setup to another setup, or even think of from say like modern medicine to integrated medicine or Ayurvedic Ayush medicine or homeopathic medicine, whatever. This type of interoperability should be there. Along with that, we need transparency, we need security, data security, as well as interoperability. I am not sure how it is possible, but what I can assure, or what I am damn sure, that with the technological advances we are bringing forward, we are going through, this must be a success or must be a fact, maybe within few days or so. Why we should think of it? It has a huge economic impact. The return of investment, it's obviously the whole process what I have imagined, what I have portrayed, that it needs lot of investment. But this investment will be worthy if we can get the return properly. So estimated that widespread adoption of digital preventive screenings and proactive health management save trillions in global healthcare cost. There may be issues like which nation, how, what is the percentage of budget. I'm not going into those nitty-gritties, but it is likely to give a return of investment on this prevention, precision prevention, or digital health prevention, digital health setup can be a big, huge amount. The process, how we are going to change it from the data collection to the engagement, everywhere we are moving towards beneficial, towards we are getting some benefits, but many more benefits, like lot of more benefits are yet to come, and we are looking forward. But the best, the like toughest, I should say, the toughest part is the health setup workers, health service providers. They should be more equipped than the patients, as well as patients must be equipped, but the healthcare providers, health service providers, they should be more equipped with the advent of digital improvement. This digital improvement, not only like it is something like you have a like for the students particularly, you have a huge syllabus, and another syllabus is another almost equivalent syllabus is being added up with things, and you need to learn these things, you need to improve these things so that you can follow, you can be useful in the market. market growth and its adoption is very important. We are talking about we are witnessing the health market, how there is exponential surge in that. But this surge, this innovation is not of any use if it is not accessible to the public. So, as people say, innovation is only successful if it is accessible. Exactly. How it is accessible? By both ends. If patient is aware, patient is digitally literate, only no use. Doctor or health service providers, they are literate only, no use. Both both of them, they need to have a big partnership between these, the great partnership between these two. Global disease surveillance is a real-time integration from labs and environmental monitoring system to predict the outbreak. We have seen corona. We know how to, now we are well prepared relatively, but we should have a integration. We have seen great integration between the nations, but there is more required so that the threats, global threats, health threats can be leveraged by technology. And we need to know about the biotechnology breakthroughs. It's like fantastic, but how many of us we can access them? How many of us we know about them? How many of us can really afford them? Big question. So we need to make it available. This is possible only when we have a nationalized or unified setup. In this respect, the virtual hospitals are coming handy. That could be a first step, maybe within, initially it can be a consortium, from the consortium to some, say, local level hospital setup where physical and integration can, physical hospitals can be integrated, and then we can bring many clinics, even like individual personalized clinics, into a setup where it can be linked through the virtual hospitals. I think we have discussed a lot about many things, and sorry, this is co-pilot. This is pilot what I have used to acknowledge. I acknowledge AIMS Jodhpur for giving me this infrastructure to share my views, Google Gemini for preparing the slides, concepts, and obviously Copilot also. And I also express my sincere thanks to the organizing committee, management, and the persons involved, whoever involved in the process of organizing this educational meet. Thank you very much. I will be happy if anybody would like to have any discussion. Thank you very much.
Thank you so very much, Professor Nayak, for your inspiring session. For our final expert session of the day, we are delighted to welcome Dr. Madhuchanda Mohanty ma'am. Thank you so much, sir.
Welcome.
Sir, I request you to please stop the sharing this property. प्रेजेंटेशन ये रिमूव नहीं होगा मैम. For our final expert session of the day, we are delighted to welcome Dr. Madhuchanda Mohanty Ma'am, Head of Department Occupational Therapy at Pandit Deendayal Upadhyaya National Institute of Persons with Physical Disabilities. And I request Professor Dr. Jasupinda Sethi Sir to kindly come forward to felicitate our speaker for the session. Dr. Mohanty's academic and clinical leadership in occupational therapy is deeply respected, and her session will bring a fitting and powerful close to our series in expert presentations today. Just sir, faculties of physiotherapy department and physiology department, and their students. The topic I'm going to talk to is I must do already about it. That is the transition from clinical practice, expertise to evidence-based practice. Though the topic disapita ho chuka hai, but it is very important and I am again stressing it. And I know fewer students are there, all must be tired, but एक कहावत है ना, जो सोवत है वो खोवत है. So I think being a clinician, academician, and a researcher, I am going to tell you some key things which is going to take you a long way. We as teachers, we are already doing it. We are lucky to be associated with this era of Chat GPT. Chat GPT को कभी master नहीं बनाना. You have to use Chat GPT as your service provider, not as your master. If you use them as your master, then you are at loss. कभी आप लोगों ने देखा है? What is I'm an occupational therapist. So let me take the example. If you write, what is the best OT intervention in dementia? Or what is the best OT intervention in right hemiplegia, Wernstrom level, stage 3?
they will give you a long list, and that is going to help you. And definitely it will help you to formulate a question, to formulate your treatment sessions. But again, you have to check the references, whether it is from our city, whether it is from systematic reviews. So these are all important things. This is being a clinical expert and going to evidence-based practice is a vicious circle. It is a cycle which goes on, and being a professional, you have got three phases. One is clinician, one is academician, and one is researcher. Being a clinician, they are high potential. They can come to research, they can come to evidence, but just academician cannot do anything. You have to be in touch with clinician. Being a clinician is always very important. So never ever kill the clinician in you. Every time you get a chance to interact with your subjects, your clients, please go ahead, irrespective of whatever position you have achieved in your life. So we all know clinical expertise है. Clinical expertise ऐसे नहीं कि साल 2 साल 10 साल सिर्फ काम कर दिया. Not that. It is basically implicit and explicit knowledge gained from direct patient contact and treating many patients over a career. Then technical excellence, superior skill in performing tests, treatments, and forming answerable clinical questions. Communication skills, fostering collaboration with patients to agree on treatment goals. Remember, client-centered treatment is always there, whether it is occupational therapy, physiotherapy, or other disciplines. So, fostering collaboration with patients to agree on treatment goals and explain clinical rationales. Reflective practice, habitually questioning standard practices and learning from one's own mistakes to improve outcomes. Then this is what is evidence-based practice. Evidence-based practice, I have done the Venn diagram. In between, you can say evidence-based practice in OT. The same applies for physiotherapy, even for physiology also. So evidence-based practice integrates the best available research evidence, the practitioner's clinical expertise. There is already research. Evidence is there, and the clinician, the expert, uses this evidence to implement on the clients to get the best outcome. And provided we have to take care of client values and goals. For occupational therapy, it is the best fit evidence, feasible decisions, and meaningful occupation. And why this Venn diagram is an overlap? Why it is important? Because we use research interventions while adapting them to individual occupational needs and priorities. Person-centered or client-centered care, values-based decision-making complements evidence-based practice by balancing evidence with what matters to the client. Professional accountability, practice guidelines from RCTs and systematic reviews. There will be single case studies also, but RCTs, they give you the highest order of what you can say, your validation, and then systematic reviews, which help any professional occupational therapist to translate evidence into clinical recommendations. These are the 5 steps which are very important. We have to first formulate an answerable question, then find the best available evidence, then appraise the evidence, implement the evidence, and then evaluate the outcome. So for formulating the answerable question, it is basically asking of well-built clinical questions, and then finding the best is to find the relevant evidence. This step involves identifying research, search terms which will be found in carefully constructed questions from step 1. The resources, it can be from PubMed, from Cochrane, and other research strategies also can be used. Then apprise the evidence. It is important to be skilled in critical appraisal so that we can further filter out studies that may seem interesting but are having weak. Use a simple critical appraisal method that will answer these questions. What question did the study address? Were the methods valid? What were the results? How do the results apply to our practice? Then similarly, we have included the evidence. Then this is again skilled in critical appraisal so that we can further it is clinical decisions that can be made by combining the best available evidence with our clinical expertise. Then evaluate the outcome. We have to again standardize tools to evaluate the outcomes. So in 2010, Malink et al. Proposed two other steps, that is, cultivate a spirit of inquiry. That is very important. Being a clinician, if you have that thing, then without this spirit, any inquiry, the next steps are not likely to happen. The irony is hospital, Dr. Neeraj, he is from a very good hospital background. I was just asking whether you have R&D department. They have n number of patients, name hemiplegia, anything, patients which you don't see. But the irony is they don't have a R&D and they don't have time even if they want to do. They are also. So that is, if we have patients, we don't have time to do research. They can give us the best evidence, but we are not able to get it. Then step 6 also has been added. Disseminate EVP results. Clinicians can achieve wonderful outcomes for their patients through EVP, but they often fail to share their experiences with colleagues and their own or other healthcare organization. This leads to needless duplication of effort and perpetuates clinical approaches that are not evidence-based. Evidence-based, these are the examples I want to tell you. Evidence-based practice in occupational therapy integrates high-quality research, clinical expertise, and client values to improve outcomes. These are established. So I'm just giving a few examples, like stroke rehabilitation. A patient with slow, unstable gait may receive pelvic stability training. So if you are not aware that this n number of research evidence is already there, which research indicates improves hip muscle strength, walking speed, and overall movement control. Then in pediatric, sensory processing for children with autism, evidence supports using sensory integration therapies to address behavioral issues and improve participation in daily activities. Then, for older adult fall prevention, to prevent falls, OTs conduct co-evaluation to identify hazards and implement specific environmental modification, that is grab rails, lighting, etc. This reduces hospital visits also. Mental health, cognitive and behavioral, evidence-based structured cognitive skill training has been shown to enhance job retention for adults with severe mental illness alongside the use of cognitive behavioral therapy principles to alter negative cognitive pattern. This I am not telling. This is the evidence which is telling, and this is backed by many RCTs. Now, case studies in occupational therapy demonstrate that from clinical expertise to evidence-based practice involves integrating high-quality research with clinical judgment and client preferences. Effective cases often show clinicians they use database searches and literature reviews to validate techniques, navigating clinical gray zone areas, gray zones where evidence is lacking, and adapting protocols to unique patient scenarios to improve outcomes. What is our drawback? We have very less protocols. We develop more valid protocols and SOPs. Because as we are weaker in developing SOPs, our profession is always weaker. So if we have to strengthen our profession, we have to have protocols and SOPs. This Venn diagram is the superimposing OT and EVP together. So effective ethical occupation focused intervention Occupational therapy focuses on participation in meaningful occupations across self-care, productivity, and leisure. Evidence-based practice adds a systematic method for choosing and justifying interventions. The overlap is where occupation-focused care becomes defensible, measurable, and client-centered. These are the common barriers and practical supports. The barriers are workload and time pressure, organizational barriers, perceived gaps in training, knowledge, skills, and motivation, and the supports are practice guidelines derived from systematic reviews, databases such as PubMed, OT-Seeker, and the Cochrane Library, critical appraisal tools, journal clubs, and outcome measurement in practice. This is an important timeline of debate about occupational therapy evidence base. It's not very far away. Kiel, Hoffner et al. Said only in 4, the evidence-based practices in occupational therapy became more pronounced in 2004. That is a need to increase outcome-focused research, but should consider context. Then Corcoran in 2006 said evidence-based practice is slow, affecting perceived value and recognition of occupational therapy. Then in 2008, K. Smith and Powell, they told that survey and case study research are consistent, but experimental and outcome research has not significantly increased despite the need to evidence intervention efficacy. Then Direct, Rosick and Wu in 2009, increased emphasis on EVP has not led to an increase in research. Percentages of intervention effectiveness research has decreased. Then in 2011, according to Gutman, researchers need to ask more relevant questions to practice, that is intervention effectiveness. Then in 2014, Paul et al., Upton et al., and Cradle et al., descriptive research based concerns about relevance and applicability to clinical problems, designs, consider holistic nature of practice. In 2015, Bagatelle and Masson, research needs to solve occupational therapy challenges within their context. In 2018, Swadrick and Noyes, more high-level research addressing occupational therapy contribution to mental health services is needed. In 2019, lowest percentage of effectiveness research published in AJOB, that is American Journal of Occupational Therapy, in 2019. Then Karila, Hiskanen, and Salminen in 2021. Need for better research instead of observational studies, there is a need for more RCTs. So the bottom line is RCTs, RCTs, RCTs. We need more RCTs to strengthen our profession. We all know that agar we have tonsillitis, pharyngitis, we are taking azithromycin and the protocol is 3 to 5 days. It has been set. Millions of studies have already told that 3 दिन ले लो, नहीं effective है तो 5 days. But then similarly, for our profession, same kind of protocol needs to be developed. Until it is developed, then there is always lapses and our profession will stay weaker. Thank you all for the patient hearing and any questions? So much, ma'am. Your session was very good. For this symposium, bringing clinical expertise and public health advances together with grace in depth. And with that, we come to the conclusion of today's Allied Health Research Symposium.
On the behalf of entire IHAS fraternity, I, Kanishka, extend my deepest gratitude to all the distinguished guests who have joined us today in person and virtually. Our heartfelt thanks to Dr. Neeraj Mishra and Dr. Madhu Chanda Mohanty ma'am who have been with us today, and Dr. A.G.K. Sinha sir, Dr. Prasunpriya Naik sir, and Dr. Olga Bedasuda ma'am for addressing the gathering and sharing their expertise on evidence-based practice. My deepest regards to Dr. Professor Jasabanta Sethi sir, Director IHAS, Professor Dr. B.C. Das sir, Dean of Health and Allied Sciences, Dr. S.K. Srivastava sir, Mentor IHAS, and Dr. Chandradeep Tandon sir, Additional Pro Vice Chancellor Research for gracing the occasion. We also and Dr. Tanveer Navid sir for gracing this occasion today. We also thank our faculty coordinators, Dr. Sanjeev Das sir, Dr. Sudeshna ma'am, and Dr. Vidushi ma'am for guiding us throughout the session. Our heartfelt thanks to our faculty members, volunteers, and students who are present here today. Your enthusiasm and engagement have made this event a resounding success. And with the knowledge that we gain today, translate to better patient outcomes tomorrow. Wish you all a great day. Thank you.